Did you know that your primary care doctor spends over $50,000 per year just to prove that they're doing a good job? Today we're diving into the maze of healthcare quality metrics, a system so complex it's driving many primary care doctors to the brink. Welcome to PCP Lens, where we journey through metrics, money, and madness. My name is Sudeep Bansal and I'm a primary care physician in Connecticut, and I run my own medical practice. From mysterious codes to endless paperwork, I'll show you why measuring healthcare quality has become a nightmare for your local doctor's office, and why your doctor is spending more time clicking buttons in the electronic health record than spending time with you. We discuss why your doctor's office is constantly trying to collect and submit data to insurance companies than answering your phone calls. Let's dive in. The National Committee for Quality Assurance, or the NCQA, is a non-profit organization that was established in 1990 to measure, analyze, and report how well health organizations provide scientifically recommended care. To achieve this objective, NCQA sets the standards for quality measures in healthcare. These standard metrics are called Healthcare Effectiveness Data and Information Set, or HEDIS measures. NCQA certifies healthcare entities for a fee to ensure that all health entities are following the HEDIS methodology to collect data and use their standardized logic to calculate and report these metrics. NCQA certification ensures that quality performance can be compared across health organizations. While CMS still defines some metrics, it borrows heavily from NCQA, and most of these metrics used in CMS quality reporting program today, they follow the HEDIS methodology. With this background, now let's look at the anatomy of a typical quality metric. The first is the quality measure itself. It defines the appropriate process or outcome that's being measured. Next is the denominator. This defines the total number of patients eligible for a specified measure. That is, the population to which the metric applies. For example, everyone between age 18 to 75 and a prior diagnosis of diabetes. Next is the numerator. This is the total number of people that meet the specific criteria defined by the measure that will enable the patient and the doctor to meet the quality metric. For example, in the denominator that has a hemoglobin A1C of less than 9%, they become part of the numerator. Next are the exclusion criteria. These define the specific reasons why a patient who was part of the initial population, which is the denominator, should not be included in the final calculation of the metric. That is, conditions that would disqualify the patient from being counted. For example, a person who's enrolled in hospice. Next is the reporting period. This is the time frame over which data is collected and the metric is calculated. Again, for example, January 1st to December 31st. And the last is the data source, which defines the sources from which data will be collected to calculate the metric. Examples of data sources include lab values for hemoglobin A1C, billing codes for diabetes eye exam, or the colonoscopy report itself. Even with this basic understanding of the anatomy of quality metrics, you can imagine why collecting accurate quality data is challenging and time-intensive. For practices that don't have the resources, they will appear as non-compliant on the quality metrics per standard reports that are put out by insurances and other government agencies. In reality, this is a data collection issue. The practice may not have the staffing or resources to collect and submit lab values. For example, hemoglobin A1C for diabetes control, BMI measurement, or to submit scanned reports such as colonoscopies or mammograms. Or the office was unable to track down or did not receive fax reports from the previous PCP or the specialist. The actual non-compliant rates on quality metrics is a lot lower than what it is portrayed out to be. This is the reason when you talk to doctors, they say that the quality data being publicly shared is incorrect. According to an article in Health Affairs, it took approximately $50,000 in 2014 to 2015 to collect and submit this quality data. That dollar amount is now much higher due to inflation. As you can now see why the reported quality data often does not reflect the quality of care. It mostly reflects the ability to collect and report the data, which gives an advantage to large organizations. With this background, let's dive into the devilish details of how quality data is collected and submitted to insurance companies to prove that we provide good quality care. The most common method of reporting quality is via regular CPT codes, sometimes also called CPT-I codes, and ICD-10 codes that are used for billing. CPT, or Current Procedural Terminology Codes, are a set of medical codes used to describe medical, surgical, and diagnostic services provided to patients for billing purposes. For example, 99214, this CPT code is used when the doctor addresses medical problems that are moderate in complexity during an office visit. ICD-10, or International Classification of Diseases 10th revision, are a set of diagnosis codes that represent medical diseases or symptoms. Medical providers use these codes when billing for services to tell the insurance company the reason for performing the service. For example, E11.9 is used to bill for type 2 diabetes without complications. Therefore, if an established patient were seen by their doctor for an office visit, you would see two codes on your explanation of benefits: 99214 representing the office visit and E11.9 representing the medical reason for the office visit, in this case, diabetes. With this background, let's apply this principle to how an insurance company will give credit to the PCP or ACO for a diabetic eye exam. Our denominator is any person who had a medical visit for diabetes, let's say in the last 2 years. The insurance company will include the person in the denominator if they have a CPT code for a doctor's visit, such as 99214 with an ICD-10 code of E11.9 for diabetes. Now that the person is included in the denominator, the patient needs an eye exam to be included in the numerator. If the person sees an ophthalmologist who bills an office visit CPT code of 92014 with E11.9, then the insurance company will consider the quality metric as being met. But what if the patient switches insurance plan after getting an eye exam? Or the eye doctor builds a vision-only plan, which is separate from the regular health insurance. The insurance company in this case will consider that the PCP is non-compliant as per their records. That is, the patient did not get their diabetic eye exam. The onus is now on the PCP's office to find the eye exam report and submit it to the insurance company to prove that they're following the diabetes guidelines. Next are CPT-II codes. CPT-II codes are $0 codes submitted to insurance companies as part of an office visit as supplemental tracking codes to indicate that the patient should be counted in the numerator. For example, here are the codes for diabetes hemoglobin A1C control. 3044F is used when the most recent hemoglobin A1C level is less than 7%. 3051F when it is between 7 to 8%, 3052F when it's between 8 to 9%, and 3046F when it's greater than 9%. The American Medical Association developed these codes to decrease the need for medical record abstraction and chart review, which would hopefully decrease the administrative burden on physicians. However, using and submitting these codes come with their own set of challenges. Due to the diverse conditions we treat, PCPs use a wide range of CPT and ICD-10 codes. The rules and regulations of these codes, they change frequently, and the rules may be different for different insurance companies. CPT-II codes follow the same pattern. Using CPT-II code takes additional time if the PCPs enter these codes in the electronic health record themselves, or if they need to hire a credentialed biller. This increases overhead costs. Furthermore, even though these codes themselves are standardized, each insurance plan makes its own decision on which codes it'll accept. In practice, PCPs submit CPT-II codes without knowing which, if any, insurance plan will give them credit. Some EHRs have tried to automate billing CPT-II codes to make the workflow easier for PCP offices. This works well for discrete values in the EHR, for example, hemoglobin A1C documented in the lab value feed, but falls apart if the hemoglobin A1C value is in the endocrinologist note that was faxed to the PCP. Remember, PCP is the one responsible for submitting the data. Before we look at the challenges of CPT-II codes, let us look at how bills are sent to insurance companies. When providers submit bills to insurance companies, they enter both the CPT-I and CPT-II code along with the ICD-10 codes in the electronic health record. This bill is then sent out in what is called an 837P file. Some EHR systems will map the paper CMS 1500 billing form into the electronic 837P file and send the bill out. This 837P file is received by a clearinghouse, which scrubs the claim to make sure that it is accurate, and then forwards it to the appropriate insurance company. The insurance company then reimburses the provider for those codes. The CMS 1500 form has space for only 6 CPT codes. Since sick patients may undergo multiple office-based tests, all 6 lines may be used by CPT-I codes to bill for service that was rendered to receive reimbursement. This leaves no space for transmitting the $0 CPT-II codes to the insurance company. Many EHRs have moved to the ANSI X12 standard instead of using the CMS 1500 for submitting bills. The ANSI X12 electronic billing standard attempts to solve the problem as technically there's no limit to the number of CPT codes the EHR can submit. However, then you run into issues with clearinghouses and health insurance plans' ability to process these codes. If the provider submits more than 6 CPT codes, there's no guarantee that these codes will reach the insurance company or will be processed to give them credit for meeting the quality metric. Some health plans, depending on negotiation, may accept supplemental data to allow the PCP office to prove that they've met the metric. Every insurance plan defines the quality metric for which it will accept supplemental data and the format in which it will accept it. The first type of supplemental data are spreadsheets. The insurance company defines the formatting of the Microsoft Excel or CSV files that a PCP office can use to submit supplemental data. This allows the insurance company to ingest the supplemental data into their database and credit the PCP. However, each insurance company requests spreadsheets in a different format, even for the same metric. For example, Aetna and United may want a different CSV format for hemoglobin A1C values. EHRs are not designed for this function, so the PCP office must now build or buy a data warehouse to submit data to the different insurance companies. The next is chart abstraction. Since patients often change insurance plans, the new plans will request copies of medical records as proof that the person underwent the care and close the gap in the quality metric, such as a colonoscopy or mammogram reports. The office staff has to find the documentation in the individual patient's medical record or call the medical office that may have the document, such as prior PCP of the specialist. Once the record is found, then the office staff needs to submit it via fax or upload it to either the insurance company website or a third-party vendor contracted by the insurance company. And this entire process is complicated by HIPAA. The office staff needs to figure out if the request is genuine so they don't inadvertently release the record to a fraudulent company posing as a representative from the insurance. And a lot of time, offices have no idea if the request is genuine because the requests that we receive, they look genuine. Calling insurance companies to verify these requests wastes hours as we are put on hold, and generally the first level support has no idea. The healthcare industry as a whole has no way of figuring out how many records are being inadvertently released in the name of quality, as insurance companies aggressively penalize practices for not submitting records. Given the exorbitant cost of reporting quality measures for physician practices, there is a movement to computerize the collection and calculation of quality measures, with hopes that it will reduce the burden of quality measurement. Electronic clinical quality measures, or eCQMs, they attempt to measure quality by computerizing the logic of all the elements that I discussed in the anatomy of quality metrics before. That is the numerator, denominator, exclusions, reporting period, and the data source. This computer logic takes the data present in the electronic health record and then calculates if quality has been met. The central problem with eCQM is that while the logic may be accurate, it is only as good as the data that's fed into it. Therefore, it does not solve the data abstraction problem. It just changes how you report it. For example, eCQM can develop a logic to meet the criteria for colon cancer screening. But if the data does not exist in the PCP's EHR, the PCP office still needs to find the colonoscopy report. All eCQM does is change how the PCP office will submit the report. So instead of faxing or uploading to the insurance portal, the PCP office may have to follow the EHR's best practice to trigger the eCQM logic. While eCQM attempts to solve the problem of electronically measuring the quality metric, we still need a way to submit the data. Enter Quality Reporting Document Architecture, which is a standard technical format to share quality data from the electronic health record. This is similar to the clinical document architecture that is used to share clinical data information using a health information exchange or an HIE. QRDA1 format is used by hospitals to submit individual patient-level data, while QRDA3 format is used by outpatient doctors to submit aggregate quality report data for all patients seen in their offices. Since PCPs bear the burden of reporting quality metrics, PCP offices or the ACO will have to use QRDA3 to submit data to CMS. In addition to other methods described above, as not all quality measures are in eCQM format. Therefore, eCQM and QRD3 data submission creates an uneven playing field and penalizes independent practices. Large organizations that use the same electronic health record across all specialties will have more data in the system making it easier for them to submit data. Since insurance payments are increasingly tied to quality, small independent practices will end up with reduced reimbursements due to these reporting challenges. Digital quality measures, or DQM, they take eCQM one step further by using data from disparate health systems, not just the EHR, to measure quality. These other systems may include a health information exchange, payer claims data, care coordination systems, state immunization registries, etc. The biggest benefit of DQM is that it reduces the burden of primary care by using standardized data sharing protocols such as FHIR to collect data from other health systems that may not exist in the PCP's EHR. For example, if a PCP does not have a colonoscopy report in the EHR, DQM could automatically retrieve that from the gastroenterologist's EHR via health information exchange and credit the PCP. NCQA's vision of quality is that health organizations will maintain a system called Electronic Clinical Data System, which will collect data from all the disparate systems, compute the logic to calculate quality, and submit the data to NCQA. What this means is that the PCP's office, or ACO, will need to buy a separate data warehouse to collect all this data and submit it electronically to health plans. eCQM and DQM appear to improve on the current data collection methods, but it has taken us over 10 years to implement Clinical Document Architecture, or CDA, to share clinical data. CDA is still bogged down by standardization, even though it is a standard, as different health systems have their own version of CDA. And we risk going down the same path with QRDA. We are starting this long and arduous journey of eCQM and DQM for data collection and reporting, while AI lurks around the corner. You can find a written version with references to the material that I discussed in this video on PCPLens.com. You will also find an audio podcast version of this video on PCPLens.com. Please like and subscribe, as this helps me find a wider audience and spread the message. Thank you for watching this video. Take care and goodbye.